Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humor and a lot of heart. So pull up a chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins. I'm Dr. Rebbecca Hertel. I'm a board-certified osteopathic family medicine physician and a Menopause Society certified practitioner. I have a private telemedicine practice and I see patients in several different states.
I am Dr. Aoife O'Sullivan, a board-certified family physician and Menopause Society certified practitioner, and I see patients through my telemedicine practice here in Oregon and Washington.
I'm Dr. Christine Hart Kress, a board-certified women's health nurse practitioner and menopause certified practitioner, and I see patients via telemedicine in several states as well.
Hi everyone, today we're thrilled to be joined by Dr. Sabrina Sahni, a powerhouse in women's health who somehow manages to bridge the world of breast medicine, menopause, and survivorship with ease and humor. She's a board-certified family physician, dual fellowship trained at the Cleveland Clinic, and now part of the Mayo Clinic team in Jacksonville, Florida. She's a Menopause Society certified practitioner and a nationally sought-after speaker who's passionate about helping women navigate midlife with clarity instead of confusion. We're talking about the intersection of breast health and menopause, what every woman should know, what most clinicians still get wrong, and why hormones shouldn't automatically be treated like a four-letter word. So grab your coffee, your patch, or your sense of outrage and settle in for a conversation that might just rewrite what you thought you knew about your own body.
Welcome, Dr. Sahni.
Thank you so much for having me. I'm so excited to be here.
Thanks so much. I know on Sunday, thanks for taking some time out of your day. And we were just saying we're all still recovering from the long menopause society. So at the time of this recording anyway, and getting ready to travel again. So yeah, it's just like whirlwind, right?
Yes, it's one thing after the other, but it keeps things exciting, I think.
Yeah, absolutely. So I am amazed. So interestingly, we were able to chat for quite some time at the FemHer Entrepreneurship Leadership Summit and at the gala there that they had the dinner. And so it was just so much fun. Like, I think we were in a corner with my daughter Lexi for so much of the night, just chit-chatting about so many different things and menopause and breast health and all of that. And I was like, you need to please come on our podcast so we can talk all things breast health and menopause. And so here we are.
I'm so excited. Yes, I know. I think I might have cornered you at the gala a little bit, but it was just fun. And I think, it's such an important topic, especially for women in midlife. And there's so much misinformation and there's so much confusion about it. And I think women are just kind of told right off the bat, kind of like you said, like it's just sort of a no-go if they, have a family history or if they've had a history of breast cancer, or if they have these atypical breast lesions that, hormone therapy in and of itself is just sort of off the table. So I'm excited to kind of break through some of those myths and talk a little bit about some of the actual data behind it and help women kind of understand what's true and what's not.
Yeah.
When a patient comes to see you, what in general are you dealing with? What do they come to see you with and chat about?
Yeah, so I see a wide variety of different patients. So I see everything from patients with benign breast disease that come in, a benign breast complaint. I see patients that want to come in and talk about their breast density. I see breast cancer survivorship patients. I see a lot of new breast cancer diagnosis. So a lot of patients coming in with a new breast biopsy consistent with an invasive cancer or DCIS and trying to help them sort of navigate that, talking to them about what surgery might look like, what chemo might look like, radiation, and kind of outlining that plan. And then, a lot of the patients that I see sort of in the high risk setting, we talk a lot about imaging, and a lot of those patients, interestingly, and many of which always have a lot of perimenopausal and menopausal concerns. And I tend to ask a lot of those questions when I sort of just meet them off the bat. And so we do tend to have a lot of those discussions about, perimenopause symptom management. What are they using? Are they interested in using anything? Are their symptoms bothersome? That sort of thing. And I think a lot of times patients will sort of tell me like, well, my symptoms are fine. Like I'm good. I don't want to do the hormone thing or anything like that. I have a family history. My mom had breast cancer, right? And so a lot of times what I sort of notice is that it takes a couple of conversations for me to sort of say, okay, well, that's fine. It's not a total contraindication for you to not use hormones, but if they become more bothersome or something that's really impacting quality of life, just know we have options available. Hormones are an option. If you are not comfortable with that, we also have a good toolkit of non-hormonal options as well. But just know that you don't have to live with these symptoms and think that you have to power through. And so that's sort of how I sort of start a lot of those conversations, knowing that, hey, you have options here, and just know that they vary from hormonal to non-hormonal as well.
So I have a question, maybe starting at sort of maybe a little rudimentary, but I think there is a lot of confusion about breast density, if you have dense breasts, what the correct screening is, because sometimes I see patients coming to me with, having a screening mammogram, and then I see women who've got heterogeneously dense breasts, and I'm not seeing a breast density summary on their mammograms. Yeah. And then I'm also not seeing that they have ever had a breast ultrasound. So what are your thoughts on density and appropriate screening?
Yeah, so technically the laws changed in September of 2024 such that women essentially need to be notified if they have dense breast tissue, meaning category C or category D. So that statement should be on there. And I tell women
reports.
What was that?
On all mammogram reports.
Yeah. Like they should be getting a letter every single year. And I tell women, like, you're going to get this letter every single year. This is not like a one-time thing. This is going to be a repeated thing. So long as you have dense tissue, this will be a repeated letter that will essentially say the same thing. And now, as of September of 2024, that it's now taken sort of a step further to such say that like women should have a conversation with their physician about supplemental imaging, that density is a risk factor, independent risk factor for breast cancer, and they should be offered some form of supplemental imaging. I am a firm believer, truthfully, that if you have category C or D density, that the sensitivity of your mammogram is limited, and you should be offered that conversation, right? I've had plenty of patients that have told me, I don't want it, and that is completely their choice, right, and in their right. But I think every single woman should be offered it. Every single woman should have that risk assessment where they're calculated with their lifetime risk, that Tyrer-Cuzick model, which takes into account their breast density, their family history, obstetrical history, menstrual history, whether or not they've had biopsies, and they can get an actual number. So let's say, for example, their lifetime risk falls less than 20%, but they still have dense tissue. I still offer some form of supplemental imaging. And I would say a lot of that is subject to what's available around you or at your institution. So that's widely variable across the country, to be honest with you. So, and a lot of that can also be determined by insurance, unfortunately. So some people are only offered things like an ultrasound. Some people are offered things like MRI and have a lot of issues with coverage for that. If you have things like fast MRI or the abbreviated MRI, that might be a nice kind of financially better option for you if that's something that's available to you. One thing we offer at our institution is called MBI, or molecular breast imaging, somewhat unique to kind of our facility, but there are options. And I definitely think that the uptake of breast cancer risk in each of them is helpful, and I think it should definitely be offered to these patients.
Want the Dusty Muffins at your next event? We do panels, live podcasts, and talks that bring the heat, literally. Corporate, CME, or retreats, we've got you. So hit us up at thedustymuffins333@gmail.com or DM us on Instagram at thedustymuffins.
Yeah, sometimes I see that Tyrer-Cuzick on their mammogram report, and again, and other times I don't see it.
It would be nice to have it on every mammogram report.
It would be. I mean, should we be calculating? I'm trying to. Is it should we be calculating that Tyrer-Cuzick, or if we just use the Gale risk model, it'll calculate it for us?
I would probably use the Tyrer-Cuzick, to be honest with you. If it's on a mammogram report, it's usually being done by radiology, and I don't know every system is sort of done differently. So truthfully, I will rerun it. There are different models. I've worked very closely at our institution with, the way that the company that they use is Volpara. It's very, very accurate. If I rerun it, it's within a percentage, to be honest with you. I think our techs are very, very good at running that. But I think it's worth running it on every patient, to be honest with you. I mean, I think the model isn't perfect, right? I think there's definitely overestimations in biopsies for sure. There's overestimations when you get to extremely dense breast tissue. I think it can definitely overestimate risk. But again, I think women that have extremely dense breast tissue should definitely be heavily counseled on supplemental imaging.
Mm-hmm. Yeah, I'm not seeing that density C or D on any reports. I see them, scattered fibroglandular density, or I'll see heterogeneously dense, but I am seeing nothing coming up on, I'll have to ask the patients if it's in their letters.
Really? So it should say, category A, B, C, or D. I would say about 50% of women fall into category C or D. And usually if you break it down, it's maybe like 40% C, 10% D. So overall, it's probably a smaller amount. And I would say majority of which are probably in that sort of like pre to perimenopausal age range, because again, your density can improve with time and with age.
And for our listeners, can we just explain why dense breast tissue, they need the supplementary imaging, or why that changes their risk?
Yeah. So essentially what your breast density is the proportion of fatty tissue to sort of fibroglandular and stromal tissue in the breast. So when we look at a mammogram, that fatty tissue shows up black and that dense tissue or that stromal tissue shows up white. So cancers also show up white. So I always say you're kind of looking for white on white, and it can really limit our ability to see very small breast cancers. So the idea is if you have a lot of white when we're looking at a mammogram, we kind of want to do something in addition to that to make sure that we can sort of see through that to get really optimal imaging every year. Independent of our inability to sort of see that, if you have really dense tissue, we sort of know that in and of itself is an independent risk factor. So not only is it difficult to see, but just having dense tissue in general, in and of itself, puts you at a slightly higher risk. Category, like you had mentioned, there are 4 categories. Category A and B are sort of not as dense. Category C and D are sort of our 2 denser categories.
Awesome. Yeah. Thank you. I think that's important because I think sometimes, they don't understand why, or, I think even some clinicians, it's missed on, why that is, you know.
Right. And if you code it as dense breast, insurance will pay for that screening bilateral breast ultrasound. I find that getting them a breast MRI, I need to add that if their tyrocusic is over 20%, then I can get that paid for.
Yeah. That, or you've got to have like an atypical biopsy, and you've got to sort of say like, based off this atypical biopsy, her lifetime risk is, 25 to 30% based off population-based data. And I bold it, underline it, put it in the notes so that somebody from the insurance company is reviewing it and can see that number. Yeah.
Do you recommend genetic testing? You had talked about family history. Are you recommending genetic testing with a primary breast cancer history for those patients coming saying, I'm afraid because of my mom?
If their family member was diagnosed under the age of 50, yes. If they were diagnosed with a triple negative, yes. If they have a family history of even metastatic prostate cancer, family history of ovarian cancer, if they themselves have had an individual breast cancer and subsequent recurrences, yes. But if you came in to see me and you had a family history of breast cancer, a family history of breast cancer in a grandparent and they were diagnosed at 85, I'm a little less inclined to do it. I always say about 7 to 10% of all breast cancers are related to sort of a true identifiable genetic mutation. So overall, it's a very small piece of the pie. And I always say genetics is very different than family history. So even though we've ruled out a mutation, it doesn't change the fact that your risk may still be influenced by having a family history, right? And usually, if a breast cancer presents and is related to a genetic mutation, usually it does occur premenopausally. We tend to see it occur a little bit earlier in life. Not all the time, but a lot of times. Yeah. So.
You have 2 fellowships and the Mayo Clinic, working at the Mayo Clinic at the moment. Was there something in particular that drew you to women's health in the first place?
Yeah. So I was one of those people that like probably wanted to do everything in medical school. I like remember coming home being like, God, I'm going to do ophthalmology. I'm going to do ophtho. It's done. It's a done deal. I'm going to do derm. It's a done deal. And I eventually was like, okay, I think I'm going to do family medicine. I kind of wanted to do sports medicine. I kind of gravitated towards like working with female athletes. And so I kind of like gravitated towards that like female patient, right? Then I did my OB rotation and I was like, okay, I'm obviously going to do OB, right? So when I applied for residency, I actually applied for both family and for OB. And I decided to rank more of my family medicine rotations just because, truthfully, if anybody is listening to this is an OB, I just think I wanted a better quality of life. I didn't think I wanted to deliver babies for my entire life. And that's just a personal choice. I commend anybody and everybody that did that residency program. You guys are all amazing. I could never have done it. I applaud all of you. I could never have done it. So when I did family medicine, I very quickly realized that there was like a huge void in like midlife women's health. I really thought that I was going to do more like, you know, teen girls, female athletes, and kind of go that route. But in family medicine, you see a wide variety of patients, right? I went to a family medicine program that had a pretty heavy OB program as well. And so I thought I was going to kind of do a little bit of that. And I started like realizing all of these midlife women patients would come to me and like, honestly, I didn't know what to do. I didn't know what to do with their symptoms. I would go to my preceptors. We would all just sort of like, you know, I was sort of taught that hormones were not an option a lot of the time. I'd be giving a lot of, gosh, I cringe saying this. I'd be giving a lot of antidepressants out, thinking that that would help manage a lot of these symptoms. Wasn't even comfortable at the time using vaginal estrogen. And I was like, gosh, is this really what happens? Like, I almost got to the point where I was like, I don't know that I even accept this for myself. Like, I don't know that I want to be fast forward 25, 30 years. And this is like what's going to happen to me. So then I started doing like just a lot of research on my own. I found some organizations that kind of did a lot more like women's health and started doing some research into women's health fellowships to see if I could just kind of get more broad spectrum. So that was at the end of my first year of family medicine residency, actually, and tried to schedule an away rotation second year. And that's when I reached out to Cleveland Clinic. That's when I met Heather Hirsch, actually. Yeah. And so I went and rotated. She was doing her fellowship at Cleveland Clinic. So I went out there for a week, rotated there, interviewed, and then basically did the fellowship right after I graduated.
Oh, that's awesome.
Yeah. Obviously the best decision I ever made.
That I know. That is amazing. I wish, I say to myself all the time, I wish I would have known it was there because I'm not far. I'm 90 miles from Cleveland, and that would have been just so amazing to do.
It really is like eye-opening.
Yeah, because like you, and I think Aoife, you know, Christine did women's health as a nurse practitioner. She has done that forever. But, you know, for family medicine, even in a field, I'm the same way. I had a really great women's health OB focused family medicine. And I was the same way. I'm just like, I don't know, you know, let's take you off. Yeah, it's the smallest dose for the smallest amount of time. We need to wean you off of that now. You've been on it forever. You know, and we're like you, we just feel terrible.
Yeah. So Sabrina, is that how they taught you there? Like Heather Hirsch is so, you know, when I first came across herself and Louise Newson were just blowing my mind. Like, what? Everything I was taught is a lie. And she was so forward thinking and so hormone positive and listen to your patient, believe your patient. Is that what you got taught there? Is that where or did you both kind of go in thinking those things and that just, you know, encouraged you to treat your patients?
I definitely can't speak to what Heather went into it thinking. Because I was a couple of years behind her, but I definitely went in wanting to just like learn everything. And our program director, I mean, she was brilliant. I mean, she was incredibly forward thinking. She taught us.
That was Dr. Holly Thacker, right?
Yeah. She taught us literally, showed me everything I know about menopause and hormones, and, you know, definitely got me connected and made us read every trial, made us do every read every study, do every paper, you know. It was a very comprehensive 2-year fellowship that got us involved with not only menopause, but we had like, you know, pelvic pain clinic, we had colposcopy clinic, we had breast clinic. And that's why I met Dr. Holly Peterson, and I did her fellowship after that, because I just like spent a lot of elective time, and I absolutely loved what I learned with her. So then I was like, all right, well, I'm going to do that after this. And then we kind of got a little bit of freedom where we got to just sort of choose. I worked in like REI for a little bit if I wanted to. I did like Urogyn clinic, and it all just kind of like intersected, right? Like all of these disciples of women's health, like went back and applied to like the midlife women, like the midlife patient, right? Like osteoporosis clinic, we got to go, we could work with rheumatology. I mean, it all just kind of intersected, and it was so nice to see everything in a different disciple and kind of put it together.
And so progressive, because like nobody knew about it and nobody was doing that. And, you know, I'm a little older than everybody. And, you know, the only thing we gave everyone was birth control pills, Prem-Pro if you weren't bleeding. We did do I was taught a lot of vaginal estrogen, and then Prem-Phase, which was if you were bleeding, you got Prem-Phase, but they never called it perimenopause. And all the other things that patients would come in for, I was kind of taught, well, there's nothing we can do about that. Go see your primary. And so I applaud the fact that you recognized so early in your career that it could be done better, and then went and found that education and kept going. And, you know, even like, you know, breast medicine and menopause, you know, they're often siloed. And then, you know, you live right at the intersection of like two of the most complicated things that women are, you know, need the most help with. What does that look like for you day to day? Menopause and breast health, like you were talking about the ADHs, and I'm curious about the LDH, those high risk patients, and how you counsel them.
Yeah, it can be very challenging. You know, I think I don't ever consider it a true contraindication. I think I said this when I even spoke at NAMS. I never really treat, you know, a menopausal patient based off a lifetime percentage. I mean, clearly I'm treating a BRCA patient whose lifetime percentage is 70% at times, right? And we have good data that supports the use of estrogen in those patients, right? So now why am I suddenly gatekeeping somebody whose lifetime risk is 30%? That's also really struggling, right? I mean, we have good options available for patients that have breast concerns, genuine breast concerns, right? I mean, Duave is a really, really great option for those patients, and I utilize it a lot. We don't have good data in that patient population, and quite frankly, we don't have data on how hormone therapy impacts breast cancer risk in those lesions, right? So all of this is sort of theoretical, right? Is there probably some sort of theoretical risk? Maybe, probably a little bit, but I always say, like, if your risk is 30%, maybe it goes to 32%. I don't know, right? But it's probably not skyrocketing to 80% with a couple years of hormone therapy, right? It can be challenging because, you know, there are a couple factors. One, like, what is your density? Do you have a family history on top of it? Two, you know, like, was this high risk lesion surgically excised or not? How big was it? You know, if it's LCIS, was it pleomorphic? Was it classic? There's a lot of like slight nuances associated with it. People might think I'm a little bit of the wild, wild west because I do tend to give a little bit of hormones in that patient population. Certainly if you don't have a uterus and I'm giving estrogen alone, I'm a little bit more comfortable, to be honest with you. But perimenopause I find to be slightly more challenging because now I can't use the Duave, right? I have to like cycle you a little bit. I kind of have to like navigate a couple more nuances with that, but it's never off the table. But I also, at the same time, I do really strongly believe in risk reducing medications. I think they're really, really effective. And I think, you know, there's a way to sometimes utilize both. Like I've sometimes said, you know what, like if you want to go on hormones for a couple of years and you want to go on raloxifene, which I think is a great underutilized medication, great for the bones, like you can do that after 5 years and still get benefit, right? And I think there's still going to be a lot more, hopefully, good data on Duvet in that high-risk population. I think there is ongoing trials, specifically in high-risk patients. I think out in California, they're looking at it in high-risk populations. And I would argue that it's probably going to show really promising results.
So you don't use Duvet off-label in
I find it
premenopausal
difficult to get insurance coverage, truthfully. I don't know if you guys have had similar pushback with that, but I have found it very difficult.
I never get insurance coverage anyway. I always have to use like a GoodRx coupon or sometimes the manufacturer's coupon. I was going to ask you, have you found a better way?
Yeah. In postmenopausal patients, knock on wood, I've had okay, but in the perimenopausal patient, I sometimes I'm like, just don't even tell the insurance, or if you don't have a uterus, that's the other thing. I'm like, how did they know? Like, who don't tell them. Like, don't tell anybody you don't have a uterus. Like, don't say anything. Just walk up to the pharmacist, get your medication and go, right? Like, so I find it really difficult because those are the things that, kind of gatekeep whether or not you can use it. And I wish that basodoxifene would be separate, because I think that would be a total game changer.
Just had this
game changer.
Just had this conversation several times. We've all had. Would be fantastic.
Yeah.
So I wonder, is Dr. Holly Thacker available to serve on the Menopause Society at any point?
Yes.
Maybe bring us forward 20 years. That would be nice.
Wouldn't it be great to do virtual fellowships now? Oh, man. And breast fellowship. How long was the breast fellowship? Was that a year or two?
It's a year, but I was able to do it in less time because I had spent so much elective time with her that she was like, you know what? We can wrap this up a lot quicker if you want. I was like, great.
That's amazing.
Yeah.
That's amazing.
Be part of, I think, just as a family medicine, especially women family med, it needs to be incorporated into the education, both of those things, because like you're right, most women, they're either going to do internal medicine or they're going to do, and even internal medicine if you're taking care of midlife women. I mean, it just is one of those important things that we have to be taught.
Right. And you have to be asking the right questions, right? Like, I think so many women, don't even talk to their doctors about these things, or they talk to their OBGYNs thinking that that's the person that is going to, like, the only one that's going to know how to do it. But like, I think all physicians should really be trained in this. It shouldn't just be limited to like OBGYNs, like primary care, internal medicine, like those are also people that should also be on the front lines of being able to sort of manage this too. It shouldn't just be like one field. There's a lot of women. There's a lot of women to treat. So
yeah.
And it should be incorporated right from day one. Like when you're learning about mood disorders.
Yeah.
Part of that training should be mood disorders are very hormone based in women, and cardiology. One of the reasons for palpitations, changes in your estrogen levels. So it has to be incorporated right from day one so that everyone has this basic understanding, and it's on your differential diagnosis list, always.
I agree.
But now at the moment, it's not on anyone's differential diagnosis in general.
Do you guys think it'll change?
Over time.
No.
I think it's going to take a long time.
I mean, we're always hopeful.
We're always hoping.
It just seems so slow.
It's so, yes, exactly. Yes, slow, that was kind of, it's so slow.
Rebbecca, your daughter's in med school. Is she feeling like any changes in like the women's health curriculum? Like,
I will tell you that they had a 1-hour lecture by a certified menopause practitioner. So she was excited about that.
Okay, so that's at least something.
Yes, so that was it.
But like we didn't have
in
that.
med school. Yeah, because I don't remember having. I'm sure we did not have that 20 years ago.
No, I think I had 5 slides, right? Yeah. And it was like Women's Health Initiative.
Yes, because I started right at the
right?
Yep. So it was a full hour, which was really good. And I looked through her lecture. I thought they did a nice job.
Good.
So, but they just need, they need more for sure, but it was a great start. So
I think you're right in terms of like, how do we like go through teaching people about cardiology and not acknowledging the fact, like, everything, all I was taught was that women present differently, period. And that was it. Right. So like, I take my boards and I'm like, okay, so the question on my boards is going to be that a woman's going to come in with like atypical chest pain, quote unquote, and that's going to be it. And then like everything else is going to be centered around a male. Right. Or like a postmenopausal woman is going to have a fall and break her hip, but like that's it, period. And like nothing else about it. Right. So we've got to like really change the narrative on this.
Like, yeah, we missed the whole explanations why, right? Because that would have made sense. Like, why do they, 60% of women have hip fractures, or 60% of the hip fractures are women? Why is it the number one killer of women, cardiovascular disease? Like all those whys. I know it doesn't make any sense that we missed kind of like,
even the physiology of like estrogen receptors and like the change that happens during perimenopause and menopause, and like I feel either I wasn't at that lecture or like it just didn't happen.
But it was the whole way through. Like when I think back, not once did I ever ask why. Like you were taught, well, women in their age 45 to 55 get frozen shoulder, plantar fasciitis. Never once did I go, well, why that age?
Yeah.
Why? And no one ever mentioned it either. It was just like you say, something you're taught. This happens to women between this age and this age.
Okay.
And no mention of, it's like this huge chunk left out that you're just supposed to guess at.
Yeah.
So you work in academia, and, the thing that I find challenging, and I want to really know if this is really what it's like in clinic or if it's just on the national stages and at the Menopause Society meetings, because it appears that academia is waiting for the perfect randomized controlled trial, the perfect data before they will actually, echo these things work, even though we see it in clinical practice. Do you see that shift changing, or do you see people like treating perimenopausal women, with progesterone because they know it helps? Because patients say it helps with sleep and mood. I think that's where, we're getting this split. And that's where I think patients are coming out of the academic centers and looking for other providers who are willing to treat based on observational data and even just, all the patients we have.
I think there are some that do that. I will say that I always tell patients that we don't have good randomized control data, but I would say observationally, this has helped patients. And if we could try it, and see how it works for you, right? Like that's part of individualizing medicine, right? And that's also what we've been taught as residents and fellows and all of these things, that like guidelines are guidelines. And we're never going to have big RCTs on a lot of this stuff, at least not in my lifetime. So like, are we just going to let women sort of struggle during this time period without sort of saying like, okay, well, we could try it. Again, is it going to be incredibly harmful? Right. Like look at the patient's individual risk factors. You wouldn't give it to somebody if it was going to be harmful to begin with, right? But it's two schools of thought, I think, to be honest with you.
Can we just say there's not studies there, but there also isn't harm. There aren't studies that show that it harms. Like women over 60, right?
Yeah.
Starting a woman who's more than 10 years. You check their cholesterol, blood pressure is good, coronary calcium looks great. Okay, it's not going to reduce your risk, but it's not going to increase your risk. So let's try it because we know it works in a lot of women. Like it's just, I think it's frustrating, and I worry coming out of the Menopause Society meeting. When you have a sold out program and now we have all these MSCPs out there. So women are like, cool, I'm going to get the care that I'm going to get on hormones. And then they get told you're perimenopausal. I don't prescribe testosterone, which is a provider's right. Or I can't give you progesterone, you're still cycling, you don't need it, or you had a hysterectomy. I told Rebbecca and Aoife and, all of the providers that are out in, telemedicine and concierge care. I'm like, well, the good news is at least for the next 5 to 10 years, our practices will be alive and well because patients are going to be leaving those institutions because providers will only act on exactly what they know.
It's true. It is very, very, very true. And it's unfortunate, I think. And I think there needs to be a healthy balance, if you want my honest opinion. There really needs to be a healthier balance. Like it's one end of the spectrum, and then there's definitely another end of the spectrum out there. And I wish that there was more people sort of gravitating towards the middle.
Yeah.
Because like I said, we're not going to have data on a lot of this stuff.
Feeling off in midlife? I'm Dr. Rebbecca Hertel, and I offer concierge telemedicine across multiple states focused on hormones, weight, libido, and sleep, and longevity. Let's get you thriving. So visit www.osteopathicmidlifehealth.com.
And with the Menopause Society being our society, we are always hopeful that they will tell it like it is. Yes, we don't have randomized controlled trials. We don't have trials that show harm, lots of observational data. And really, when you have X amount of observational data, does that not really equal?
Yeah.
I mean,
at a certain point.
Yeah. At a certain point.
Yeah.
I mean, come on. But this year, and I mean, every year we leave with a lot of the talks having been quite negative towards hormones and whatnot. But this year was a whole other level. Like, I could not focus thinking of all the new clinicians in there, just soaking up all this information and going to practice exactly like they've been told, which means that a lot of women are going to suffer when they go back. And those, you know, I felt like I was being gaslit, honestly. With all these talks, progesterone does not work for sleep. And here's me having seen thousands of women who come back and want to hug me because they've slept for the first time in 4 years on a little bit of progesterone. I mean, that's gaslighting, right?
I've definitely talked to a couple of people that were first timers, and I've just said, it's definitely more nuanced than this.
Yeah.
All I'm going to say is that it is definitely more nuanced.
That's what I told my girls.
Yeah.
Yeah. Because I was like, oh.
It is a bit of an art. I will tell you, it is not black and white. It is a bit of an art. And I will tell you, I told people this, I was like, I think perimenopause in general, that is a bit of an art.
Yes.
And like, that is not black and white. And I do not think it is like guideline this, guideline that, because that can be a very complicated space.
Yes. And every woman
is different.
I mean, and we know every woman in menopause is different.
Yeah, totally.
Surely every woman month to month in perimenopause is different, right?
Totally. Yes.
But you did do really great at the Menopause Society. And I was like, were you nervous? Because there's some people up there on the panel.
In my room, and my heart, it was like 125, and I wasn't even in front of anybody yet. And I was like, oh my God, I should have taken a beta blocker before this. Like,
really scary.
Yeah, I was very nervous.
Yes. Well, Risa was up there. And I was like, oh boy, it's going to be good.
I definitely wasn't expecting the first question. What do you think about hormone therapy and triple negative breast disease? I was like, okay, well, we know benign breast disease, but okay, let's. Yeah. I have 6 minutes.
That was on purpose. And I was like, that was not nice, but okay.
Okay, there is a plenary on this.
But you did great.
Okay. I was like, that's also a very nuanced conversation.
Yeah.
What were some of the other questions that surprised you?
Definitely that one. I was like, oh gosh, I was like getting a little hot in here.
For our readers, or listeners, do you want to answer that? What do you think?
I will say, oh God, it's tough. I will say this. Even the Menopause Society position statement says that in the event that a woman fails all non-hormonal options, even in the setting of estrogen positive breast cancer or even estrogen negative, that hormone therapy is not off the table. So that is a guideline driven statement. Okay. If somebody is very much so struggling, yes, I have absolutely given it to a triple negative. I have also given it to a young DCIS ERPR negative patient that's had a bilateral mastectomy, who's been diagnosed in her 30s, who's been cycling for 10 years and then suddenly gets to menopause. And so why am I gatekeeping? Right. So there's all these nuances where you're like, so how does that justify not giving somebody hormones when she's basically been making her own estrogen this entire time? Similarly, in an estrogen positive breast cancer, right? Mm-hmm. Like somebody that's ERPR positive in DCIS, that's bilateral mastectomy, where tamoxifen would not be indicated in that case, right? She's having her own cycles. She may even go get pregnant, right? And it would not increase her risk. But suddenly now I'm gatekeeping it, or told to gatekeep it at the age of 50, right? 49, 48, something like that. There's no perfect answer. And I'll tell you, I've also had, on the flip side, working in a breast center, I've also seen the one-off cases of the triple negative that come back with metastatic disease that's suddenly estrogen positive. And you're like, how did this happen, right? And so I have definitely seen both ends of the spectrum. And it is so dependent on their stage, how they were treated. Were they fully treated? Did they complete chemotherapy? You know, if they have intact breasts, like what did their breast imaging look like since? Family history, genetics. So I would say not off the table, but it definitely should be very individualized. And I would probably reach for a lot of my non-hormonal options first. I think lifestyle is huge in that population. I think survivorship, again, is a bit of an art. I think lifestyle is incredibly important in that. Exercise, diet. I think, you know, there's a lot of interesting data on GLP-1s in that space. I think there's a lot more to come, but I definitely think it could be somewhat game changing if we get good data in the future. But I have no problem with my patients that are on it currently. But I think it can be really, really helpful. And again, if you're failing non-hormonals and you're really, really struggling and you understand the risks, like, yeah, I'm not going to make you suffer. Like, yes, my goal is you don't have a recurrence, but also like I have to value your quality of life.
Right. I think even within the oncology community over the last few years, there has been a real acceptance of women with triple negative cancer going on hormone therapy after their treatment. Yeah. Have you joined forces at all or come across Rachel Frankenthal over in California?
I have not.
She's a PA and she set up a survivorship clinic for women with GYN cancers. But I bet the two of you would have the best conversations.
Oh, yeah, I would love
She's wonderful.
Yeah. I can share her with you, her information too. And if you, so speaking on the oncology, you know, are there things that you wish oncologists and menopause clinicians could talk about together more often?
I wish that there would be somewhat of an openness to talk about some of these menopause concerns and openness to talk. I think women deserve to have a discussion on hormones, whether or not people are utilizing them. They deserve to have a discussion about them, right? I think the vaginal estrogen discussion can sometimes be very difficult to even break barriers on, despite the fact that we have good data, despite the fact that hopefully this black box warning will go away. Even still, that conversation, I think, can be very, very challenging.
Yeah, absolutely. And I really wish, you know, when we start saying that, you know, everybody in residency should be taught about menopause, I am kind of getting to the point that as menopause clinicians and practitioners, we really need like a high risk breast, like, you know, training. I mean, we really do, whether or not we decide, you know, to take that upon ourselves or not. We need, you know, some training type fellowship type, you know, whether or not you go back and do that. I mean, most of us at this stage, I can't imagine doing, you know, taking time away from a job and all of those other things to go get another fellowship or get a fellowship training. But, you know, I think those are, there's not many of you around, right? It's like Corinne Men, there's only one of her, there's one of you. I mean, there's just not, and maybe we need to get some better resources like that for even us to work with.
Yeah.
You know, when we are seeing these patients, because we all see breast cancer survivors here.
Yeah.
So
it's very hard, you know, and again, just comes right back to that nuance, right? And treating every single patient like their own, you know, that is that one special case. But very hard to watch any patient say, you know, my life is not worth living at the moment.
Yeah.
I have no quality of life.
Yeah.
And, you know, they've been to see their specialist and been told, you know, no, this could increase your risk of recurrence and whatnot. And then you take everything else into account as well. You know, what else is going to increase that woman's risk of recurrence? Being obese or overweight, being, you know, being sedentary, drinking alcohol. And these are all things that happen to women when we don't have our hormones. You know, we gain weight, our whole metabolism changes, our energy is low. We drink some wine to see if we can get to sleep that night or treat our anxiety. And so when you look at the whole picture, like for that one person, when you weigh up the risks and benefits, like that's so helpful to look at the entire picture. And I think some patients, of course, are so grateful to be alive and their oncologist saved their lives that they don't even feel like they can tell them sometimes that this life that I have now, I feel like it's not worth living. Like I'm so depressed. So you really do have to just focus on that one person at a time. And you can't generalize at all, can you?
No, it's so true because like, each person, especially since I see a lot of these patients as they come in at the time of their diagnosis, like it really changes like the fundamental idea of their life, right? Like it's a totally life-changing diagnosis, right? And I'm not going to sit here and pretend to understand how that feels, right? I've seen patients younger than me get diagnosed with a totally life-changing diagnosis, all the way up to 50, 60 years older than me. That also is a life-changing diagnosis for them. And I can imagine it is incredibly difficult to navigate. And on the back end, I kind of feel like they feel like they have a new normal. They don't have to have sort of this new normal, right? It doesn't have to be like this. They can go back and get parts of their life back the way that it was, right? Like maybe there is some element of a new normal, but like it doesn't have to be this poor quality of life, and they don't have to necessarily be defined by this diagnosis, right? Like I just wish that women would know that they could advocate for themselves in that way, because there are so many options and there are so many treatments and there's so many physicians and clinicians out there that are so passionate about helping women in this space and with this, with any, well, truthfully, any cancer outside of breast, GYN cancers, any cancers in general, that like you can definitely live a very good quality of life if you have the right resources and and team behind you. I really do believe that.
Well, tell our listeners where they can find you.
Sure. Okay, you can find me at Sabrina Sahni MD on Instagram. And I am in current practice at the Mayo Clinic Breast Center in Jacksonville, Florida. So we are taking, again, high-risk breast patients. We have a whole women's health department there as well. So again, happy to see anybody that wants to come and that's in that area.
Oh, it's been wonderful having you on today. Thank you for joining us.
Thanks so much for having me. This was so fun.
That was Dr. Sabrina Sahni reminding us that women deserve more than vague answers and pink ribbons. We deserve evidence, nuance, and individualized care. If this episode gave you a few, wait, why did no one ever tell me that moments, share it with a friend or a clinician who needs to hear it. And don't forget to follow the Dusty Muffins wherever you get your podcasts so you never miss a single myth-busting moment. Until next time, keep your estrogen balanced, your questions loud, and your muffins unapologetically dusty. Or not dusty, we prefer, really.